Okay, so welcome again to this anatomy MCQ series, 10 MCQs. I'm Dr. Ankit, anatomy professor and faculty of anatomy at Next. Let's start the first MCQ without wasting any further time. 65-year-old woman is injured in an automobile accident. Examination indicates she suffers fractures of left ribs 8 to 10. So there's fracture of left ribs 8 to 10 and profuse internal bleeding. Which of the structures indicated in the given CT scan of the abdomen will likely need to be surgically removed? So anatomy roll over here. Fractures of left ribs 8 to 10, which organ lies in front of those left sided ribs, or which organ has the axis around the 10th rib and lies around 9th, 10th, 11th, all those ribs? Answer is the organ is spleen, right? That could also lead to the bleeding, and let's see where is the spleen in the CT scan. So options given over here are A, B, C, D, E. That is the right side, the left side, anterior, posterior. We know spleen lies in the posterior lateral part on the left aspect. So option number C, this appears to be like the spleen. Let's explore more. A over here should be the liver, right? B over here is more anterior, could be a gas shadow in the fundus of the stomach. D over here is the, can say, is the erector spinae group or the extensor muscles. E over here would be a vessel, that is the aorta. That is the aorta over here. So therefore, answer is option number C, right? So what is the answer? Answer is option number C over here. C is the spleen. That would be our best answer, right? Okay. Let's see the location of the spleen anatomically. Here you are seeing the what we can say the rib cage, the lower part of rib cage, and this organ over here. This is our dear spleen. Therefore, if you have a fracture of the left ribs, 8, 9, 10th, 11th, the spleen is prone for injury. Okay. Let's see the second question. A 4-year-old male is admitted to the hospital with a severe vomiting. Radio examination history taken reveals that the boy suffers from what? From annular pancreas. Okay. Which of the following structure is most typically obstructed by the annular pancreas? That is the question. So, annular pancreas is an embryological defect where if you go to the basic, or you can say the normal embryology, the pancreas develops from two buds, dorsal and the ventral pancreatic buds. The ventral pancreatic bud then revolves around the duodenum, behind actually the duodenum, the second part duodenum, and it fuses with the dorsal pancreatic bud. That is the normal. What happens is, when the ventral bud, instead of going only on the posterior aspect, suppose this is the ventral bud, only on the posterior aspect, it also goes on the in front of duodenum. And what happens is, these two parts of the ventral bud, they try to fuse. Then they are going to obstruct this part of duodenum, and this part duodenum is the second part of duodenum. Therefore, answer has to be the second part of duodenum, option number C over here. Understand? Let's confirm this with the help of few images. Here's an image showing us the ventral pancreatic bud, and that is a dorsal pancreatic bud. And look over here, there's a bifid ventral bud. When this bifid ventral bud goes around the duodenum, you have this condition known as annular pancreas. Annular pancreas, meaning by annular means ring. The pancreas bud forming a ring around the second part of duodenum. That is known as annular pancreas. Look at this more image. Annular portion of pancreas compressing this part of duodenum. That is the second part. That is the third part. This is fourth part, and that will be the first part of duodenum. Answer was second part of duodenum. Coming to the third question. 35-year-old male admitted to the hospital from emergency because of excruciating pain in the back and left shoulder. Okay. CT reveals an abscess in the upper part of left kidney. Okay. There is an abscess where? In the upper part of the left kidney, but no abnormality is detected in the shoulder. CT is different and sign symptoms are different. Patient came with the sign symptoms of having a pain in the back and also pain in the shoulder. CT is showing problem in the kidney. Now, kidney is retroperitoneal, so we can say that, okay, pain in the back could be due to kidney, but what about the left shoulder? So the question is, a shoulder pain may be caused by the spread of inflammation to which of the following neighboring structures? How can the abscess from the kidney involve which structure so that the pain may reach where? The shoulder region. Shoulder, what is the dermatome? That is C345, C3, C4, C5. Here comes the anatomy and the basic knowledge of anatomy. The basic knowledge of anatomy over here is Kidneys are retroperitoneal, right? Kidneys are retroperitoneal, right? You have a right and left kidney. Over the right and left kidney, what we have some amount of gland over here. What is that known as? Adrenal gland. What is lying above these structures? What is lying above these structures is, if we can have a look over here, this structure over here. What is this structure? This structure is our dear thoracoabdominal diaphragm. Okay. Now they are saying that the abscess is in the upper part of left kidney. So imagine the abscess is right over here. This abscess, if it starts to irritate, this abscess, just a second, this abscess, if it starts to irritate the diaphragm, what is the nerve supply of diaphragm? The motor nerve supply of diaphragm and even the sensory supply in the middle part of diaphragm is phrenic nerve. This phrenic nerve, if you remember, having the root value of C3, C4, 5. कुछ याद है? C3, 4, 5 we just studied. Dermatome of the shoulder. Okay, that is also the dermatome of the shoulder. So phrenic nerve would have been irritated over here. The referred pain would have gone or should have gone from the phrenic nerve to the region of shoulder, right? So it is basically involvement of the question is, the shoulder pain may be caused by spread of inflammation to which of the following neighboring structures? The neighboring structure over here would be what? Would be the diaphragm, the thoracoabdominal diaphragm, because of relation of the diaphragm to the kidney. Let us see in this images as well. These are the right and left kidneys shown, and also shown their posterior relations. So first, to understand the image is posterior relations, not the anterior but the posterior relations of kidneys, right? Kidneys already are retroperitoneal. Look over here, you have the psoas major muscle. This is the psoas major muscle, that is the quadratus lumborum, and here you also see the diaphragm part over here. That is how the you can say the referred pain would have reached. Again, an image over here showing you the left kidney and the diaphragm part which is lying over here. Let's see the fourth question. During dissection of a deep pelvic lymph node in a 60-year-old, the surgeon accidentally severs the internal pudendal artery at its origin. So internal pudendal artery is cut at the origin during dissection of the pelvic region. Internal pudendal artery. Which of the following structures will maintain its normal blood supply immediately following the lesion? So they are asking which structure out of these four is not supplied by the internal pudendal artery. Now, internal pudendal artery is a branch of. We have discussed earlier also that this artery is the main artery supplying which region? Perineum. Okay. The internal pudendal artery comes from which artery? It comes from the internal iliac artery. Okay. Therefore, this lies in the pelvis. So that tells us, okay, in the pelvis we have this internal pudendal artery. Now this is the artery of perineum. So what will it supply? It will supply the structures in perineum. In the perineum we have an anal triangle, we have a urogenital triangle, right? Posterior and anterior. Internal pudendal artery is going to supply them. The lower part of anal canal, in the perineum, the superficial pouch structures and the deep perineal pouch structures. Look at the options. The four options over here, one of the options should not be lying in the perineum. That would be the answer. Or we should know its blood supply, which is not coming from interpudendal artery. That would be the answer. Let us go one by one. Penis over here. Now penis you can you know that lies in the perineum, right? So it can easily be supplied by interpudendal artery. Bladder, urinary bladder, is an organ of pelvis, and the blood supply of bladder is vesical arteries, superior inferior vesical arteries. They are branches of internal pudendal artery or internal iliac artery. They are coming directly from internal iliac artery, not from the internal pudendal artery. Therefore, what is the answer? Answer we already is out. Answer is the urinary bladder. Let's explore more options over here. Anal canal and scrotum, they are again lying in the anal triangle and the urogenital triangle. So they are supplied by internal pudendal artery. Answer over here is urinary bladder. That is the answer. Let us see an image over here. Here is the image. What is this image showing us? This image is showing us this is the aorta. Okay, that will be the common iliac artery. See, I am writing. And this over here, if I zoom it out, this over here, this vessel over here, this is the internal iliac artery. And you can see over here that this is giving off branches like the superior vesical artery over here, right? This is superior vesical, and in males it also gives off inferior vesical artery. Then where is internal pudendal artery? Internal pudendal artery is going separate over here. This separate. It's going around the ischial spine, behind the sacrospinous ligament. Remember, this is sacrospinous ligament, and entering where? It's going to enter in this region. What is this region? This region is perineum. It's going to supply structures over here. Internal pudendal artery. Also, do remember that this internal pudendal artery, it runs along with pudendal nerve in a canal that is known as pudendal canal or Alcock's canal. I hope the point is clear. Let's come to the fifth question. 31-year-old lady is in her physician's office for a fitting for a IUCD. The physician performs a pelvic examination to ensure that the device is placed in the correct direction. Interesting question, listen carefully. The physical examination shows that the uterine body is tipped forward towards the rectum and that the uterine fundus is tipped anteriorly. So, uterine body and the uterine fundus, they are both tipped anteriorly. Which of the following describes the position of the uterus? Now, remember the anteversion, anteflexion. Anti means forward, retro means behind. Okay, we should be knowing that. Suppose we make it with different colors. This is the vagina part. Okay, this is say the cervix part, right, and this is say the uterine body and the fundus part. If we go to the angles, angle between vagina and cervix, this is anteversion angle. V for version, V for vagina, remember. If you look at this angle between the cervix and that uterine body, this is known as AF, anteflexion part. Normal anteversion is around say 90 degrees, around 90 degrees, and anteflexion, this is around say 170 degrees, around that, approximate mean number. Now, where is the rectum? Rectum normally lies behind over here. Rectomenal canal, it is lying behind. This is a normal thing, anteversion, anteflexion. Now, during a PV examination, suppose the PV examination was performed from here through the vaginal. They said that the examination shows that the uterine body is tipped towards the rectum, okay, and that the uterine fundus is tipped anteriorly. So during examination, it was seen that the body over here was tipped behind, because you can't go PV examination, you can't enter into the fundus, but you can do a bimanual examination and try to understand that the body over here is tipped towards the rectum and the fundus is going anteriorly. Right? It means that this anteversion angle is going behind, so this will be retroversion in the particular patient. And as the fundus is going anteriorly, it's going to be anteflexion. So it's a combination of retroversion plus anteflexion. If you look at the options, option number C over here. This will be the best answer over here regarding this particular question. If you look at this image, the angle of anteversions and the angle of anteflexion is what I already told you. In front lies the bladder, behind lies the rectum. And if you look at these different things over here, this is a normal thing, anteversion, anteflexion. Both of them tipped anteriorly. This is retroflexion. Uterus is still anteverted. Okay, so there is anteversion, but there is retroflexion. Look over here. In our answer was what RV and AF, right? Our answer was retroversion, anteflexion. Okay, this was the answer in that particular question. The uterine body looked like going towards the rectum, but the fundus was moving anteriorly. This is your retroversion, anteflexion, the one that was asked in the question. And if both are going back, we call them as retroversion and retroflexion. Remember this, a very important part. Sixth question says, an abscess is detected between the perineal membrane and the inferior fascia of the pelvic diaphragm. In a 27-year-old man, which of the following structures would most likely be affected by this abscess? So what is perineal membrane here? We should know. Perineal membrane is the inferior fascia of urogenital diaphragm. What is urogenital diaphragm? Urogenital diaphragm is basically a combination of sphincter urethrae and deep transverse perineae The lower margin, this is perineal membrane. What does this mean? This means that this muscle I said sphincter urethrae, this is deep transverse perineae. These muscles form the urogenital diaphragm and they are lying in the deep perineal pouch. It means that below the perineal membrane, this area we have superficial perineal pouch. Remember, basic anatomy of perineum. Abscess is between the perineal membrane and the inferior fascia of pelvic diaphragm. The inferior fascia of pelvic diaphragm. Okay. Now this we have to understand, where is the pelvic diaphragm? Pelvic diaphragm is actually a combination of your iliococcygeus and your pubococcygeus muscles, right? So they are asking then, where would the pelvic diaphragm be? Pelvic diaphragm is supporting the pelvic structures. Now, what will be lying above over here? Suppose this is a male. What is the structure lying over here? A huge structure. I'm making it small because of positive space. But just imagine it to be the urinary bladder. Behind there will be a rectum, obviously. The pelvic diaphragm actually will be coming like this, right? And they are saying, where is the abscess? Between the membrane and the inferior fascia of the pelvic diaphragm. So this is, imagine the inferior fascia of pelvic diaphragm. So where is the, what we can say, the abscess is lying in this area. Which space is this, deep or superficial pouch? Deep pouch. So we know that the abscess is in the deep perineal pouch. Now, the question is, which structure would be affected? Now, what are the structures lying in the deep perineal pouch will be the answer. Bulbourethral gland. This bulbourethral gland over here, it lies in the deep perineal pouch. It is actually the answer over here. In males, obviously. Though remember, if I try to make the bulbourethral gland with this yellow color, it lies around over here. Just a second. Okay, 1 second. Yeah, this will be the location of bulbourethral gland. But do remember that it's duct open down in the superficial pouch. That is a trick over here. But do remember the bulbourethral gland itself lies in the deep perineal pouch. This will be our answer. All these three options, B, C and D, lie in the superficial perineal pouch. Or you can go otherwise. If you don't want to go to all these concepts and all, though you should, right? They are not that difficult, but still if you have less time, no problem. Be smart, try to choose the odd one out. Out of these four options, B, C and D are lying in superficial pouch. Only option A lies in deep pouch. So which structure will be involved? The structure will be involved will be the one which is obviously not, which is the odd one out. That is option number A, the bulbourethral gland. Okay, this is how we can go. If you look at the images over here, this is the image over here. Now see, where was the abscess actually lying? That is actually more important. This is UGD, that is the perineal membrane. This is the perineal membrane. And this is the inferior fascia of the pelvic diaphragm. Abscess was lying over here in the deep perineal pouch. That is the point. If you look at the male part over here, here you can see these are all the bulbospongiosus and perineal membrane is over here. This is the deep pouch. This is the deep pouch. Just a second. Deep perineal pouch. And this below the perineal membrane, this is all superficial perineal pouch. This is deep perineal pouch. The bulbourethral gland actually lies right around over here, though they are duct open in the superficial pouch. That is the whole point. Okay, this you can understand. This is the inferior fascia of pelvic diaphragm. This is the perineal membrane. So where is the abscess? If I try to again draw it again, this is the location of the abscess. So which organ is involved? Bulbourethral gland is involved. I hope you got the point. Let's move on to the seventh one. In which of the following layers would a lowered rate of cell division be most likely to hinder implantation of the blastocyst? We all know that blastocyst is formed around day 5 and then it starts to implant around day 6. Implantation starts around day 6. And when the blastocyst is formed, you have an outer covering known as trophoblast and an inner known as the embryoblast. Okay, the trophoblast divides into two parts, cytotrophoblast and syncytiotrophoblast. Right? The cytotrophoblast means the cells. Syncytio means they form a syncytium. So actually what happens is the cytotrophoblasts are the ones which are undergoing the cell division. And cytotrophoblasts give rise to syncytiotrophoblasts. These are the ones, cytotrophoblasts are the ones which are going for implantation. Embryoblasts are the ones which are having the, you can say, epiblast cells which are going to form all the cells of the body. But the implantation and the nutrition is to be given by the trophoblast. This you should know. Now they are asking which layer out of which of the following layers a lowered rate of cell division would be most likely to hinder implantation. Obviously, if cytotrophoblasts start to decrease the rate of mitosis, there will be decrease in syncytio. It is going to hinder the process of implantation. You can understand. Answer is not syncytio, answer is cytotrophoblast. That is my point over here. Because the cell division is not occurring in syncytio, cell division is occurring in cytotrophoblast. Have a look over here in this image. This blue color is actually the inner cell mass or embryoblast, and this outer part is your trophoblastic cells. And in this trophoblastic cells, the syncytium over here is, this is syncytium, and this over here will be the cytotrophoblast. But the division is occurring from the cyto towards syncytium. This you have to understand. Again, embryology, the development of the embryo depicted in this illustration is typical of which of the following embryonic period? Week 1, week 2, week 3, week 4. Slightly tricky question. Let's see. How to guess which week is this? What are the points which you can take from here? Remember here, what we can do is we can look at the somites, right? We can also look at this neural tube openings over here. So how many pair of somites are over here? Let me just zoom it. Let me count with you guys. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. There are 17 pair of somites. The somite stage starts from day 20 and it goes around 10-11 days till day 30. So around 10-11 days it continues. It forms around 35 to 40 pair of somites. So daily around, you can say daily around 3 to 4 pair of somites are formed. So days, you have 17 pair of somites. So how many days? Approximately 4 to 5 days have gone by. Think, daily 3 to 4 pair of somites. At least 4 to 5 days minimum. If it starts from day 20, you have 20 plus 4 or 5, it is around the day 24 or day 25 of the embryonic period. Now we have deciphered the approximate days, if not weeks, approximate days. Now day 24, day 25 is which week? Now, simple maths. 1 week has how many days? 7 days, very good. So 0 to 7 is week number 1. 8 to 14 is week number 2. 15 to 21 is week number 3. 22 to 28 is week number 4. It is around 24 or 25 days. So lies in, got the answer, it is week 4. Simple as that. Right? So apply a common sense and you will reach the answer. Okay. 9th one. Again embryology, that which structure is derived from the same embryonic primordia as the spinal ganglia. Spinal ganglia is a posterior root, also known as dorsal root ganglia. Derivatives of all the germ layers, ecto, meso, endo, and neural crest cells is a very important. Neural crest cells, remember, they give rise to all the ganglias, all the sensory ganglia, simple as that. So therefore, DRG over here is given of neural crest cells, but here they are asking, apart from this dorsal ganglia, which other is coming from the same parent or same neural crest cell. So over here we know that out of these options, adrenal medulla also comes from the neural crest cell. So this is the answer over here. Kidney, mesoderm, liver is also meso plus endo. Lungs lining by endoderm. Here we can look at all the derivatives, very important slide of neural crest cells. And here we can see adrenal medulla right over here and the spinal dorsal root ganglia right over. These were the points asked in the question. Remember to learn all of them, take a screenshot and enjoy. Last question of the session. I hope you guys are enjoying. 7-day-old newborn with a diagnosis of patent ductus arteriosus undergoes surgery to ligate the ductus arteriosus. During the repair, the surgeon takes special care to avoid injury to a closely related nerve. The surgeon is protecting which of the following nerves? Ductus arteriosus, a duct connecting the artery. Which two arteries? It is connecting the aorta and the pulmonary trunk, particularly we can say the left pulmonary artery. If I try to make the ductus arteriosus by this, right? So this is arch of aorta, this is PT pulmonary trunk, that is your ductus arteriosus. So it remained patent, surgeon went to ligate it, and then surgeon is worrying about a closely related nerve over here. There is a closely related nerve over here. Which nerve is that? That nerve is a branch of the left vagus that goes around the ductus arteriosus, and then that nerve actually goes around ductus, then it goes behind the aorta, and then it goes above, supplying the muscles of larynx and supplying the sensory supply to the lower half of larynx. Which nerve is that? On the left side. That nerve, a branch of left vagus, is the left-sided recurrent laryngeal nerve. This is the nerve which the surgeon has to take care. Though remember, it is not just the left recurrent laryngeal, but actually the left vagus is also very close, and then vagus is actually going down. This is the left-sided vagus nerve. Let us see with an image over here. Look at this image. I'm trying to just zoom it. This is the left vagus nerve, 10th nerve, vagus nerve, and see over here. Here you can see how it gives off the left recurrent laryngeal nerve, and then that ascends up, and this is your left recurrent laryngeal nerve over here. Let me just try to highlight this and this. Just zoom it for you guys to see. This is the left recurrent laryngeal nerve. So what about the right side? The right recurrent laryngeal nerve is given off below the right subclavian artery. So it is slightly higher up. Okay. So these were the 10 MCQs. I hope you guys are enjoying. Anything else, write in the comment box. All the best. See you soon.